Hello, everyone, and thank you for joining today's webinar on Children's HCBS Plan of Care Workflow and Medicaid Managed Care Service Authorization. Before we get started, we're going to run through just a few quick housekeeping things. We are hoping to have time for Q&A at the end, so please submit your questions via the chat. The chat should be available on the right-hand side of your screen. If it isn't available yet, you can click it. You can access it by clicking the little thought bubble on the bottom toolbar. And please chat in all your questions to the host. And again, we hope to have some time for Q&A at the end of the presentation. Additionally, the slides and the recording from this presentation will be posted to the CTAC website, so you will be able to access those after the event. And with that, I am going to turn it over to our state partners who are going to begin the presentation.
Good afternoon, everyone. This is Colette Pullen from the Department of Health, and we appreciate you joining us on a Friday. So our goal today is to present the Children's HCBS Plan of Care Workflow and Managed Care Plan Service Authorization. And we're really targeting this to our HCBS providers. So we had previously provided a webinar on August 28th regarding the plan of care workflow for everyone. And we heard from stakeholders that it would be helpful to review this workflow specifically with the lens of the HCBS provider, and that we had a number of questions regarding service authorization. So we thought this would be helpful for us to present those two items together. So we're just going to go through the purpose of the workflow and the policy. There's a couple links in the webinar slides of where the policy is posted and the forms are posted. And then we're going to walk through the steps, and then we're going to talk about service authorization and continuity of care. There's also a number of things that are in the appendix to be helpful to you, and we did recently send out the slides to anyone that's on our listserv as a designated HCBS provider, but as Caitlin just mentioned, we can send the slides out. They'll be posted for anybody else that's on the call. And this slide deck will look very similar to August 28th. With some added pieces, as I mentioned, specific to the HCBS providers.
So, hi, welcome everyone. This is Hope Goldhaber from the Department of Health. Our first slide here is just a reminder of what we've been doing all year. In the Children's System Transformation, we started in January with bringing in new state plan services. We consolidated the waivers so that by April 1st, we had 6 children's waivers that were combined into one single children's waiver. July 1st, we aligned the benefit for most behavioral health services in the managed care plans that would be covered if the person was enrolled in the plan. And then October 1st, we now moved the children's waiver services into the managed care benefit package, and are requiring children who are participating in the waiver, they no longer have an exemption from managed care. Although there is a footnote on that we're not actually enforcing that until after January 1st, 2020. So today's workflow really speaks to how HCBS services in the children's waiver will get authorized, particularly for children who are enrolled in a managed care plan, although we'll discuss, both children who remain fee-for-service and children in plan, because that is pretty much what we're using. Now, as of October 1st, now that October 1st is here, we anticipate that health home care managers, CES, the Children's Evaluation Service, the plans, and the providers will all be using this workflow to ensure that there's the right exchange of information happening and children have access to services.
Great. So as we mentioned, the purpose is to move forward for October 1st, and our goal here is how is everybody going to communicate with one another? What is everyone's role? So to ensure, as Hope just mentioned, that CES, the care manager, the managed care plan, and the HCBS provider are communicating regarding the HCBS services. We also want to be clear that AT, VMODs, EMODs, and non-medical transportation is not part of this process, because those processes are very specific, how they need to be obtained, and there are different forms and processes for those HCBS services that are posted on our website. So just to make sure everybody is aware. As I mentioned, we did present this HCBS Plan of Care webinar previously on the 28th. There is also a finalized policy that was issued, finalized in September on the 19th, as well as the forms. And we actually have updated the forms already, I think, several times, because providers have been using them, or care managers have been reviewing them and asking to make it maybe a little bit user-friendly or a specific item to be posted. So we are receptive to feedback on the forms if it's going to make your job a little bit easier. So I just want to remind folks that we are talking about the HCBS Children's Waiver, as Hope just mentioned, and this is for children who we believe might be eligible or in need of services, and it serves all children up to age 21 who meet eligibility, so there's no specific group. And the eligibility has what we call target populations, so it meets 4 target populations. So when we combine the 6 waivers, we combine them into these 4 target areas. So the medically fragile population, the SED, our mental health population, then we have developmental disabilities with the medically fragile or complex medical needs, and then our DD foster care. We also want to just highlight for everyone, because we do get this question quite a bit, for a child that just has a DD condition, they would not be eligible for the children's waiver. We'd really direct them to the OPWDD comprehensive waiver. So just that footnote. And then I'm sure many of you are aware that HCBS, right, is for our highest needs kids. Those children who may be in and out of placements or hospitalizations or higher levels of care, to either return them home and to be safe in their community from institutional placements, or to ensure that they do not go to those higher levels of care. So that's the criteria for HCBS, and we've done a number of webinars on the HCBS eligibility process. So we thought it would really be helpful to make these slides color-coded so that everyone who is in the process can kind of see themselves. So you see that there is a little color chart at the top with managed care in blue, health home care managers green, CES is orange, and you as the HCBS provider is yellow. And so our goal throughout the slides is for you to be able to see what everybody's role and relationship is to you and the process. And we are also working on what we'll call a desk aid or a cheat sheet to break down this process even further for folks. So again, they can see what they need to do. So care management, right, in the new world order, so to speak, is 3 buckets. So you have health home care management, CS, and managed care. So health home is comprehensive care coordination for children who are either health home only or in our HCBS children's waiver. And they are the ones that develop and maintain the plan of care for children who are either fee-for-service or enrolled in Medicaid. And then, of course, health home is an optional service, but if a child is going to receive waiver, they need care coordination of some type. So we have developed our CES, so that's Children and Youth Evaluation Services, for those children who opt out, or for children that you believe need HCBS services and who are currently not on Medicaid. those children should be referred to CES, and CES will determine HCBS eligibility and develop that HCBS plan of care. So where health home is comprehensive, CES will be providing the responsibility over those HCBS services, and then they will be maintaining that plan of care for those children who opt out and who are not enrolled in managed care, so those children who are still fee-for-service. If a child opts out of health home and goes to CES and they're enrolled in a plan, then CES and the plan will work simultaneously together, where CES will still determine HCBS eligibility and will establish that plan of care, and then the managed care plan will maintain oversight of those HCBS services and communicate with CES for follow-up and for the annual reassessment. So there's a lot of co-working, collaboration going on if the child opts out of health home and goes to CES. So we have this wonderful colored chart, as I mentioned. What we did is we broke down the process into steps, where you can see here called the Milestone Event, and then we color-coded it whether the child's enrolled in a health home or with CES, and if they're in a managed care plan up here, or if they're fee-for-service. So once again, we were trying to make it easier, even though there's a lot of colors, so that everyone knew what their responsibility is, depending on where the child is, who their care coordinator is, and then whether or not they're in a managed care plan. So then we break this down into steps. So step one is the whole referral process for HCBS. So, of course, someone has identified that the child needs HCBS services or might be eligible for HCBS, so they'll be working with the health home care manager or CES, as we mentioned. And if the child is, of course, eligible, then they will sit down with the family and all the family's providers, their care team, to develop the person-centered plan of care that includes the HCBS services. So the family has choice, right? So the child and the family chooses the HCBS services, their goals that they want to work on, and their needs that they want to address primarily at this time. And then they also get to choose their HCBS providers. So the care manager would sit down with the family, review the assessment, and talk about what the needs of the child would be, and then help them to identify the services that might meet those needs, and then give them the list of providers in their area that provide those services, because we have a list of designated providers. So they're going to help the family through this process, and then they're going to establish what we're calling the first appointment. Now, this can be done in a variety of ways. So the CES or the health home care manager can literally pick up the phone and call you as an HCBS provider. They can do that without the family. They may give the names to the family to call, depending on the level or assistance the family may need, or how the assessment was developed and how they picked their providers. So this can happen in a variety of ways, but our goal here is not to wait for paper, right? Our goal is to get an appointment and make connections for the family so they can get the needed services. And then, regardless of how that process for making that first appointment happens, then the health home care manager and CES has to complete the one form we've developed here. Is called the Referral for Home and Community-Based Services to the HCBS provider. There's a picture there of the form. If you actually click on this when you get the slide deck, it will bring you to the form. And we have this form posted on our website, so there's links at the end and throughout that can bring you there. So this form needs to be completed within 4 calendar days of the referral. So a phone call is made, an appointment is set, then the care manager needs to follow up with the referral to ensure that everybody has the information needed and that it's documented. So that's really important. It's also important, there's a couple notes there that, you know, of course, we need to make referrals that are in network of the plan, so it's incumbent upon the care manager to know the child is in plan, which plan, and who their providers are. So that's very important. And also we get a lot of questions because we have some providers that work on the adult system. There's no level of care approval process or anything like that. The care manager can make those referrals to the HCBS providers. So how do you use this form? So you're filling out this form and you're sending it to the HCBS providers that are selected by the family. If there are multiple services that the family needs that are HCBS and there's multiple providers, then this form needs to be completed individually for each provider, right? Because you're going to be sending this to the provider, the HCBS provider. If there is more than one service and there's only one HCBS provider, maybe there's 2 services and the provider provides both services and the family wants to work with that agency, then only one form needs to be completed with all the information of the services, the 2 services that the family would like on that form. So each service needs to be identified, and if you look on the form, it does give you space for multiple requests for services. You need to identify the desired goal or the need that needs to be addressed. Has to be completed by the care manager and identify that HCBS provider as this is the process to document. And then the care manager should keep a copy. So they're sending this over to the HCBS provider. And again, this can be done however the HCBS provider would like it, fax, secure, email, however. Hopefully there's a dialogue and there's communication how that form should be sent over. So now the HCBS provider has the documented request of the family for those services and illustrating the need, and the care manager is keeping that form also as documentation that they made the official referral.
So Colette, could I insert here? We had received questions about how an HCBS provider knows somebody is eligible for the waiver and it's appropriate to serve the child. One of the purposes of this form is also when you're getting this from the care manager has completed that eligibility process and has gone through that process. So if this form is coming to you from a health home care manager or from CS or even from a plan, it's like you know that this person has been eligible. There is a way on eMedNey to identify somebody who is eligible, but since our goal here is to refer to services as soon as we know, that system edit on eMedNey with a K code may be a little bit behind you getting this form. So, you know, if you have any questions about that process, we would still like to hear about that here.
Yes, and I'll say on the top of the form, you probably can't see it that good, but at the top of the form, it does say over here whether or not the child was eligible for HCBS, and I believe it asks for the date, and it also a checkbox that they have received a slot.
Exactly. Right.
So that would be your confirmation that the care manager did what they were supposed to do so that you would know that. So that's a good point, Hope. So this form would also be utilized if there are new or additional services that are requested over time from the family. So as the care manager works with the family or you as an HCBS provider, identify other needs, or maybe the family says, I want to start working on X, another service is needed, then you would use this form. So again, if there's a need or a change of the HCBS provider. So the goal of this form is really to be the documentation piece for both the HCBS provider and the care manager that referrals have been made, right? And so if there is a request for a new service or a change of the provider, or during the plan of care review, you've identified new services, or you as an HCBS provider who has worked with the family, maybe you have identified a need and you've talked with the family, you would call the care manager, they would discuss it with the family, and then if a new service is needed, then they would send a new form. And this form needs to be completed whether you're the new provider or not. So even though you're already working with the family, we would need documentation of this form. And as I mentioned in the beginning with the care management, right, health, home, CS, and the managed care plans, when we mentioned those are the three entities, if the child is in managed care and managed care has oversight of the plan of care, if they have with the family identified new services, they also will utilize this form. Again, this will be the process to document the referral for everyone. So as I mentioned previously in step one, there's this need for this first appointment. This is really important because this is a trigger, especially for those children who are in managed care. So you'll see the note there. If the child's not enrolled in managed care, then you can skip this step two. So this is really important for those children who are managed care. So it's the responsibility of the HCBS provider to ensure that there's a first appointment that is scheduled, and that the managed care plan as well as the care manager, whether that's CS or the health home care manager, is aware when that appointment is scheduled. So maybe the family has reached out to you, they made a first appointment, and for whatever the reason, they missed the first appointment or it gets rescheduled, then the HCBS provider needs to notify everybody of that change, and it needs to happen pretty quickly, immediately, because you don't want to start to service that family and that child and not notify the managed care plans. And you'll see there on the slide, it says when you're notifying managed care plans, you should notify them of the appointment date, the identified service, and the goal or the need that you're trying to address. And then if there was a change in the first appointment, you would be calling and saying, you know, they missed the first appointment, and so here's the new date. So you as the HCBS provider now has an appointment with the family, and depending on your service, you're going to provide some type of intake assessment or some kind of assessment to determine whether or not the child who's presenting in front of you really has that need that's been identified, and whether or not you can serve that member based on the service that was identified, if this all makes sense to you, works with the family's calendar and schedule and yours, depending on the service, then you're going to do that process. Now, we understand that may take more than one visit, so we understand that. But your goal as the HCBS provider is, one, to have that first appointment, two, to assess and determine whether or not you can provide the service that's being requested for the identified need, and then for you to determine what we call frequency, scope, and duration. Okay? So in our policy, as well as in the appendix of this slide deck, it does define what frequency, scope, and duration. Every HCBS service must have an identified frequency, scope, and duration. So this is how you, as an HCBS provider, will work with the family and the child based on the service and the need. And then once you have determined that, again, whether that's after the first visit or after the second visit, however that assessment intake process happens for your agency and service, you will then complete the second form that we've established called the Children's HCBS Authorization and Care Manager Notification Form. So there is a link right there again. Both of these forms are on our website, and they are fillable forms, so that's good news for folks. And then when you do this, you're going to send this form to the managed care plan with the information. And this is notifying them. So we've had a lot of confusion, and we've given out some guidance, but we want to make sure that people understand that it's the role of the care manager to develop what we call a plan of care that should really include all the services of the child and what they're receiving beyond HCBS, right? And then the HCBS provider, if you're providing respite, as an example, you're going to have what's called a service plan. So that is your agreement with the family, how you're going to work with them. But your service plan information needs to get to the care manager so that information can be put in the plan of care through that frequency, scope, and duration. So what is the purpose of this form? So the purpose of this form is, one, it needs to be utilized regardless of the child being in managed care or not. So it's really going to be serving a number of purposes. And we didn't want to have 3 and 4 forms, so we tried to have a combined form. So this notifies the managed care plan that HCBS has been requested and that there is a need for continuance. So this is the form you're going to use for the first time that someone presents to you and you need to notify the plan, or throughout the duration of the service for the child, so the continuance of services. This form is also going to notify the care manager and the managed care plan of frequency, scope, and duration. And this will also inform everybody when there's an update that is needed to the plan of care. And then this is going to be the tracker of the HCBS service being provided, authorized, and the notification. So once again, this is going to be a form that everyone will keep in their file to demonstrate that the HCBS provider has worked with the family and has identified frequency, scope, and duration, the needs, the service to be provided, and whether or not it needed to be authorized. So again, as we previously mentioned in the beginning of the slide deck, there is that chart with all the colors. So we broke down the policy as well as the slide deck to explain when a child's in managed care or not, or with CS or health home, so that you know how to proceed with the child. So this slide is talking about a child who is in managed care and is in health home. So you, as an HCBS provider, has worked with the family, you've identified frequency, scope, and duration. You are going to fill out this form, and you're going to complete section 1 of the form, which really you're naming the service, the need that you are addressing, and you're outlining when the first appointment happened, and frequency, scope, and duration. And there's boxes for you to fill in there. The managed care plan will review that form. They may ask you as an HCBS provider for more information, and they will issue what we call a determination to the HCBS provider. The determination is always in writing, so you're going to receive that. And then you as the HCBS provider will complete section 2 of the form and send the form in the service authorization to the health home care manager. This is the trigger to the care manager that they have to update the plan of care with frequency, scope, and duration, and then they need to send the plan of care to the care team, the family, as well as the managed care plan. So see there's a note that the HCBS provider must notify the care manager within 5 calendar days after receiving the authorization from the managed care plan. So throughout the policy, we have given some dates, and it's really to make sure that everyone is notified in a timely manner So we recently have received questions like, what happens if it's on the 6th day? You know, we have to start all over. Well, no. Our goal, again, is to make sure that everyone is timely in their communication, because that is going to result in the best services to the family, because everyone is communicating and knowing what is going on. This next slide talks about a child who is in managed care but is not in the health home. So they are with CS. Again, the HCBS provider will complete section 1 of the form and send it to the managed care plan. The managed care plan, again, will review it and issue that written notice to the HCBS provider as well as the family about the service that they've reviewed. And the managed care plan will update the plan of care and distribute the plan of care. So they will make sure that that plan of care is shared with CES, because as I mentioned previously, CES and the managed care plans are working collaboratively together to have oversight of that child. Now, after you did frequency, scope, and duration, let's say you're going to provide services and you mentioned that the duration is for the next 3 months. You're going to provide this service if that equates to whatever service you're providing. And then you're getting close to the 3 months coming due, you would need to make sure that the plan approves an extension of those services, or if there's a change of those services. So when you want ongoing services to continue for that family, then you want to complete this form again. And you want to do this before the 3 months has ended. In my example, you will make sure that you look and revise your frequency, scope, and duration on the form, and you will complete the form. And we say here at least 14 days prior to the existing HCBS period ending. This does not, again, preclude you from picking up the phone and calling the plan and talking with them and saying, you know, I think we really need to extend this service. Again, this form is for documentation purposes, that you have presented frequency, scope, and duration, and what you want to continue to do and work with that family. So you can pick up the phone, you can send this form, but you really need to do it within 14 days prior to the services ending. So that's really important. Again, trying to use these 2 forms as the documentation throughout the process. Now, if a child is not in managed care, again, we do not want to develop a new form, so we're going to continue to use this same form, the authorization form and the notification for care managers. So if the child is in a health home and not in a plan, then you as the HCBS provider will complete section 1 and you'll send it to the care manager. The care manager updates the plan of care and distributes the plan of care to everyone. And the same applies to CES. If they're not in plan, you'll fill out section 1. CES will update the plan of care, make sure everybody has a copy. And then this just does not have section 2 that needs to be completed. So again, it's really important that everyone's communicating and has documentation of the service that's being provided by the HCBS provider, frequency, scope, and duration. And whenever there's a change, you know, communication should be happening in a multidisciplinary team meeting or a care team meeting or with the family. Family always needs to be involved. And then this form is the documentation of how you're proceeding with the services and notifying everyone. If you're going to continue with services and the child's not in managed care, once again, you're going to update this form with the continued frequency, scope, and duration, and then you're going to notify everyone by, you know, completing that step 1 in that section 1 as we just noted above. So our goal here was to have a streamlined process of just 2 forms and everyone using those forms for documentation process. So as this is proceeding, as we mentioned, this is just kind of an overview in the sense that, the care manager sits down and discusses with the family, the care team, the needs, the services. They develop that plan of care through a person-centered plan of care way where the family gets to choose the services. They're going to be looking at the assessments that have been done and talking about the needs of the family and what goals do they want to address, and then making those referrals to the HCBS providers. And then the HCBS providers will be contributing to that plan of care with their frequency, scope, and duration, and making sure that the goals are in line with the services you're providing. Now, one of the recent questions we received was, what happens if a care manager makes a referral for an identified need, but the service that they refer to does not address that need? Well, you need to have a conversation then with the care manager about what services you can provide to meet that need, or does the child need to be referred to another provider who provides a different service? So, again, this is a work in progress with everyone, and, families may be picking providers and services that might not be a great match, or you as an HCBS provider may say, you can't really address that need. So again, there has to be some open dialogue between the care manager, the HCBS providers, the managed care plan, and of course, informing the family what you can and cannot do and how you can help them to move forward. And that's why the plan of care is never stagnant. The plan of care, some people call it the initial plan of care or the ongoing plan of care. Families change over time, and kids change and have different needs. So we are saying this first plan of care, initial plan of care, is when the care manager has sat down with the family for the first time, identified those services, picked service providers, and then they should be signing the plan of care and then, making those referrals. But the plan of care should be reviewed when there's a significant life event on an annual basis, if there's a need that has changed, or a service or a provider that has changed, or if the family has requested something that needs to happen. Then again, the plan of care needs to continually be updated, and providers need to be notified. So good communication is really important. Our goal here to streamline is that every time there's a change, does the plan of care need to be signed? And so our policy, I direct you to our policy. If the need in the service has been chosen, but maybe there's a change in the provider, there may not need to be another signing of the care plan. It may, when the care manager meets with the family, then they can have that plan of care signed. So our goal here is to not make sure that, every time something's going on, we have to truck out to the family and have the family sign more pieces of paper. We need to make sure that the family is the center of anything that's happening and any changes that do occur, and that they are informed and they know what's happening and there's good communication. But I direct you to the policy about the minimum requirements for signature or what needs to happen. I think I already mentioned this, of course. As I said, the care plan is really flexible. There is a requirement in the health home program that there's a 6-month CAN. So if there's ever a change in the assessment or the needs of the family, if there's a significant life event, then you're going to be reviewing that plan of care. And then in the policy, it does outline when the plan of care needs to be sent to the managed care plan and how that should be done. And if the plan of care is not totally updated with all the HCBS services, how a care manager should proceed. with those requirements, but our goal is that within 30 days, that plan of care is updated from the HCBS eligibility determination, and that the plan of care goes to the managed care plan. Now, if the child has multiple HCBS services, then frequency, scope, and duration may be staggered from those multiple providers. So again, the care manager will have to, continue to update their plan of care and then proceed with sending that plan of care to the managed care plan. And this screen here just shows you that kids can be at different points, especially in the health home, that a child could already have been in health home and have a comprehensive plan of care, and then HCBS needs are identified. A child may come knocking at the health home door and someone's like, I need HCBS services for this child, or this child is in the hospital getting ready to discharge. And then you may only have an HCBS plan of care, and then the child may go to CES, and that's an HCBS plan of care. Again, they need HCBS services, and maybe they're not on Medicaid yet, so they need to be determined HCBS eligible first. So there's different processes and different types of plans of care at different times, but the goal is to make sure that there's communication between everyone and that the managed care plan has the plan of care, the most updated plan of care as possible. It's really incumbent upon the managed care plan to be able to authorize services when they know what the services are and they have a full picture of what's happening with the child. So, and in the policy, it does break down, as I mentioned, at different times what needs to happen, as I said, with frequency, scope, and duration, especially if there's multiple providers. So if the plan of care that was sent to the managed care plan is only an HCBS plan of care, then when it is updated by the health home, then it needs to be resent to the managed care plan. So the time frame right now is for HCBS, your HCBS plan of care needs to be within 30 days. For health home, your comprehensive plan of care needs to be done within 60 days. So if a new member comes to you and they don't have anything, then you will have this staggered plan of care and notifying the managed care plan. And then, as I mentioned, when the HCBS provider then notifies the health home of frequency, scope, and duration, then the plan of care again needs to be updated within those 30 days and sent to the managed care plan. So I think I kind of covered this in the sense of when will a plan of care need to be updated, and at minimum it needs to be done annually. But the health home program for children has a 6-month requirement for a CANS and a significant life event. So anytime there's something that may impact the plan of care, then the plan of care should be updated and then sent to all the involved parties and the multidisciplinary team. This is really just illustrating the same thing within the 4 steps. So I don't know if I went fast, but there's a lot because there's a lot of colors, and our goal again was for you, whoever you are, seeing your role in the process. And as I mentioned, I think the policy outlines, similar to the slides, whether someone's in managed care or not and what your role is. Our goal for the rest of the presentation is to talk about service authorization. So we've received a lot of questions over the last month or so about how service authorization works, and I'm going to turn this over to Hope to talk about service authorization and continuity of care.
Right. So thanks, Colette. So as Colette was walking through the POC workflow, there were a lot of times when she talked about the importance of notifying a plan, like of the first appointment, and then speaking briefly about how a plan will make a service authorization determination, and that there are timeframes within which the plans have to make those authorization determinations. And then we went back and forth about services that don't require prior authorization and services that do. One of the things that we want to highlight is that when we developed the POC workflow is we formed the pieces that connect with the managed care plans to dovetail with requirements that plans have on how they handle requests for services. So that's why some of the language appears the way it does, because we are fitting in with the way things work in the managed care world for how a managed care plan will ensure that people get the services they need and that they respond to requests in a manner that is consistent with all of the requirements that plans have in federal regulation and in state statute for responding to those requests. So I'm not going to go into all of the details about everything that has to happen in that process. We do have those materials on the department's website and in the model contracts that the plans sign. And it's also included in member handbooks, which the plans have posted on their websites. It's also included in the provider manuals, which is really important because not only do members have appeal rights, but providers have appeal rights on their own behalf. So I would encourage you that if you want to understand how a particular plan is set up for their authorization processes, to take advantage of the materials that are already posted out there. But for today, I did want to at least do a level set, particularly for providers that might not be as familiar with these managed care processes, to at least get you started in understanding what some of these basic terms are and how they work in the managed care world. So the first piece is understanding the different words. Notification means something different from authorization, which means something different from utilization review. And I think people, there's a tendency for people to kind of mix up notification and authorization. Those two things are, and those things are not necessarily all the same. So notification is simply that. It means that there's been a notice sent to the plan that something is occurring for one of their enrollees. And this allows the plan to update anything that they have for that enrollee in their care management systems and in their claims systems. In particular for the POC workflow, when you notify the plan of the first appointment, that is the trigger for the plan to understand that they need to set something up in their care management systems and in their claims systems that this child is eligible for HCBS and will be accessing services with that provider. It permits the plans to have that named provider added to their claims systems, and it opens up that period of that 60 days, 96 units, 24 hours, so that the provider does not need to do any kind of prior authorization request for those services. The plan will have that piece set up when that thing comes in, and things should just flow and work right. So when we use the word authorization, we're generally talking about that actual function. It's a general term. It doesn't mean, it could be a prior auth, it could be no prior auth, it could be concurrent auth. There's all kinds of things that are attached to that. But basically, the word authorization just means that the plan has opened up that claims window. It's any approval in the plan systems for a child to receive that service. So in the children's system transformation, as you'll see on the next slide, we do have specific. Okay. Can you go to the next slide? Yeah. We'll get there. Okay. Sorry. So we do have specific requirements of how the plans have to automatically authorize those services and open up that claims window without prior approval or utilization review. And that, like I mentioned, includes that 60-day clock for HCBS. The authorization has to be put in place in order for those claims to pay. So even where we say plans cannot require prior authorization, they can't require you to go and ask for this first, the plan still needs to have the information and put it on their claims system in order to make sure that those claims pay. If that notification of that first appointment does not happen, there's no opportunity for the plan to put that information on their systems. If you send a claim in when you haven't notified the plan, chances are very good that that claim will initially deny. and then you're backtracking and trying to figure out why it's denied, right? So that's why we emphasize, as Colette was going through the process, it is so important that that notification of that first appointment happen, and that if that appointment time changes, that you notify the plan that there's a new appointment date, because that appointment date is starting that 60-day clock. So the other thing I want to just highlight is that authorization will be needed for any out-of-network provider. So for a provider that's not contracted with the plan, if for some reason someone has to access services out of network, there's no in-network provider available, that has to come to the plan, and the plan has to have an opportunity to respond to that and set up an agreement with that out-of-network provider so that, again, that they can put that authorization on the system and the provider is known to them, and all that happens much more smoothly if it happens in advance and with as much notice as possible. So then on the next slide, I talk about utilization review. The utilization review is literally the review to determine if that specific service is medically necessary or appropriate for that child. And that there's a lot of rules around utilization review. Just because something might need authorization doesn't necessarily mean it is also going to be reviewed for medical necessity. So those two pieces, authorization and utilization review, are not necessarily always the same thing. So when you're talking about medical necessity or review of appropriateness, these clinical decisions have to be made by health professionals based on written clinical criteria of the plan. In the children's system transformation, we have set up specific parameters or when plans can conduct utilization review. And it's not an assessment of the child's eligibility for HCBS, but again, whether that specific proposed HCBS is appropriate for the individual child and likely to achieve the goals indicated in the plan of care. And it's good to just remind folks that by law, plans cannot conduct utilization review at an unreasonable frequency. So an example I like to give is that, you know, if you have a child who's in a 30-day treatment program, we would not expect the plan to be checking in every 3 days if it's still necessary for that child to be in that program once they've approved that child for the program. So those are things that we do look at when plans are setting up their criteria. For the children's HCBS, what we're looking at here, I'm going to talk about it a little bit later in the context of continuity of care. For the beginning period of time here, plans are not going to be conducting utilization review, but they're still going to need those authorizations to come in, again, to make sure the providers are set up on the system. So service authorization in general, on the next slide, I have some just like, general comments. The authorizations are always provided in writing. The providers will usually receive an electronic notification. So particularly for contracted providers, that's usually worked out between the plan and the contracted provider about how those notices are going to happen. Some notifications are required by law to be by phone as well. It really depends on, which type of, authorization it is, but they're all always going to be in writing. Once authorized, the plan can't change that authorization unless there was information that was withheld the first time they looked at it, or there's suspicion of fraud, or the person's just simply not covered, they're not enrolled in that plan. The determinations have to be made in accordance, like I mentioned before, with existing federal regulation, New York State law, New York State regulation, and there's a section of the contract, Appendix F, as in Frank, of the contract, and the current timeframes for these decisions are available at the link on our website. That's because our contract, Appendix F, is before the federal regs changed in 2016. We're in the process of updating the contract, but we don't have the new text available. So I do want to make sure that providers have the most recent time frames that plans will be making these decisions. I did pick out a couple of time frames that I think are most relevant for the plans on the next slide. And this is kind of like what we started talking about in the workflow. For the services, for HCBS that are applicable in the workflow, there's that initial period for the provider to meet with the family and do the assessment, develop the frequency, scope, and duration. that is that 60-day, 96 units, 24 hours. You don't need prior authorization for that. You just need to notify the plan of the first appointment date, and it opens up that time frame. So when you do figure out, with sitting down with the family, what service you're going to provide going forward, and you fill out your form to notify the plan and request authorization for additional services, that's called a concurrent review. And if that request for more services beyond that initial period comes into the plan before that period expires, it's always going to be a concurrent review. So the time frame that the plan has to make that decision in is here on the slide. Expedited means if there's a delay, it's going to cause harm to the enrollee. There's some kind of harm if you don't get an answer right away on a fast track. That would have to be decided within 1 business day from the plan receiving all the information they need to make that decision, and no more than 72 hours from the request. If it's a standard review, it would be 1 business day from all information and no more than 14 days from the request. And this is why in the workflow, we specifically say to providers, when you're going to request more services, you should start that request at least 14 days before your authorization period expires. And that's, I should clarify, that's before the initial 60-day period expires. And if you're, like, let's say you got authorization for like the next 90 days, before that next authorization period expires. It's always before the end of what you've already got authorized. And the piece of that is that because the plan, under our federal rules, has for a standard request 14 days to look at that request. You really want to get you don't want to run it right up to the last minute if you can avoid that, right? So then the other thing that happens in here is that sometimes when the requests come in, there just isn't enough information for the plan to understand what's happening. And there is a possibility that the plan might extend the review because they think it's actually in the enrollee's best interest to do that. In other words, if they make the decision based on the information they have, they know they're going to have to deny it because there's just not enough information to support the decision. That might not be in the best interest of the enrollee. It forces an appeal process that may not have to happen. So they're going to extend, reach back out to the providers, try to get the information they need, and that could add up to another 14 days. And that's either the expedited or standard time frame. That's just the way it works. And just in general, sometimes the enrollee or the provider may ask for that extension because they know there's more information coming that will change the decision. So they have a right to ask for that extension. So, I just wanted to kind of like illustrate here again that between the HCBS workflow, we tried to point out these specific touch points to the plans that fit within the structure of how the plans have to answer these decisions and how, the timeframes they have to make these decisions. So you should just like, the way I think providers should kind of internalize this is that I know if I send my request in on time, I should be hearing back from the plan, within 1 business day of all information, or at least within 14 days. And so if you're not hearing back from the plan within that time frame, it's time to follow up and kind of see what's going on with that issue. And again, we also, I think it's important to recognize what Colette said earlier, is that a lot of plans have faxes, they have phone calls, they have people that you can reach out directly to and do this by phone. It doesn't always have to be that paper process. We do ask that you do fill out the paper and use that as documentation of the request, but you can fax it into the plan. It's really good to like have a good working relationship with your plan and understanding how these requests need to come in. So I think on the next slide, I go through what happens if it's a prior authorization. We talk about how in the workflow, something like AT, VMODs, EMODs follow a different process. Those services do need to be prior authorized. So I just put in here that, prior authorization is what happens when there's a requirement that something needs to have prior approval before you get it. It's a new service, somebody hasn't gotten it before, or the authorization period has expired, okay? So if you've expired and you're outside the authorization period, it may be treated as a new service by the plan. There are some exceptions to that for things that we consider long-term services and supports. So for a prior authorization review, the timeframes are just a little bit different. For expedited, it's 72 hours from request. And for standard, it's 3 business days from all information, but no more than 14 days. And again, both of these timeframes still can be extended for more information for up to 14 days. Moving on the next slide, sometimes, when the plan looks at the information, there is a disagreement between what the provider is asking for, or for that matter, what the enrollee might be asking for, and what the plan sees as something that's appropriate or consistent with the goal. And in that situation, the plan may issue an adverse determination. It could be a denial. It could be a reduction. They're authorizing less than what was requested. It could be a suspension, like in the middle, you're getting HCBS, and for some reason they think things have changed. There's been a significant change, and you're going to get a termination, an early termination on that authorization. So if that happens, the plan does have to provide written notice with a detailed reason. If it was denied as not medically necessary, there has to be a clinical rationale. That again shows that there's specific criteria that hasn't been met. And there should be enough information in that notice that if you did want to file an appeal, a formal appeal, you would be able to understand the issue that you need to appeal. The notice would describe the enrollee's rights to appeal, the enrollee's rights to external appeal or fair hearing, and the provider may have appeal rights on their own behalf. So like I mentioned before, information on the appeals process are in the member handbook for the members and in the provider manuals for the providers. So some possible next steps on the next slide. If you are in disagreement, you could just simply pick up the phone. Discuss alternative service options with either the plan care manager or the family. Sometimes picking up the phone, you can clear up some discrepancies that might be causing a problem. There is something that you can do. You can, if it is medically necessary, denial, you could ask for a peer-to-peer review, which is called a reconsideration. You can file a formal appeal with the plan. I suggest that you, include any documentation for the request that you have. I'll note that if a provider wants to file an appeal for an enrollee on the enrollee's behalf, you must have the enrollee's authorization to do so in writing, and that's a federal reg. We can't get around that as much as we want to. After exhausting the plan's appeal process, the enrollee has the right to external appeal or fair hearing, and you can certainly at any time contact the Department of Health for any assistance in things that you think are incorrect processes or access issues, and where you feel that maybe the plan is not doing everything that they're supposed to do. That's why, we have a complaint line set up specifically for that purpose. So I wanted to get into just a little bit about continuity of care and utilization review. We talk a lot about how in the children's transformation, I know we show these slides in many different venues, where we set up these periods of time where we say to the plans, you cannot do UR, you cannot do that medical necessity review within these windows. And that means that if there's a service in the plan of care, actually, could you just go to the next slide? Because I think that one's more germane. If, for these transitioning children, as they come in on 10-1, they have 180 days protection of whatever HCBS, long-term services and supports, and CFTSS is in their plan of care when they come in. And that means that if there's any CFTSS that's newly identified that's going to be added within that 180 days, the plan still can't do UR on that service. We're letting the person-centered process kind of guide this as the children's transition, and as the plans and the providers and the care managers all get used to working together. We're giving an extended period of time before we then layer over any medical necessity review that might occur. So I thought it might be helpful in the next slide to kind of give some examples about what this might actually look like in a specific, for a specific child. So the first example talks about a transitioning child who was in receipt of HCBS prior to October 1st. They're enrolled in a plan, and the plan now has this 180-day period from October 1st to March 31st where they will not be conducting utilization review on that plan of care. So the plan will use the existing plan of care to authorize the services the child's currently receiving. They'll not review any HCBS, CFTS, or LTS that's added to the POC for medical necessity during this 180 period, right? So, but if there are new services added, you still have to notify the plan of that first appointment, and the plan will authorize in the context of this 180-day period. So what you're looking at here on this example timeline is day one, the authorizations are put in place for services for 180 days. On day 30, after meeting with the family, you decide that there needs to be a new service that the family is interested in receiving. You notify the plan of that service appointment. You fill out the form. You say this is the frequency, scope, duration. And then the plan would be authorizing, in this example, for the full 150 days. Let's say that that's what was requested because that's the remainder of the 180-day period. But then by day 180, you want to make sure that in advance of that cutoff point, when your authorization period is expiring, you want to make sure that you put in an authorization request for any services that you think still need to continue. And past that 180-day point, the plan may conduct utilization review from that point forward. So that's the first example. So then let's go to the second example. The second example is for a child who was not part of the transition. So on 10/1/19 and thereafter, an enrolled child, they're in managed care, they're found newly eligible for HCBS. We're using the HCBS workflow. The provider notifies the plan of the first appointment. For this child, okay, they'll not review services in the plan of care for medical necessity or appropriateness for the first 60, 96, or 24 hours. So that's that initial period that's in the workflow that doesn't require prior authorization. So on day one, there's no prior approval. The initial auth is put up for 60 days from the first appointment. Before day 60, if you think that child needs continuing services, you need to put a request in. In my example, that request is for 90 days, for the next 90-day period. The plan may conduct UR for that 90-day period. Remember, this is not a transitioning child. This is a brand new child who newly needs HCBS. So from day 60 on, the plan may conduct UR, and then it just continues. Let's say, they do approve the 90 days, then by day 50, you'll put in a new request for the next 90-day period, perhaps, in this example. I hope that is more helpful to kind of understand how this lays out. And certainly, the slides will be available for folks to kind of look at that and then ask any questions as they have a chance to review it. So let's see, what else do I have here? I think we added in a little bit more information about the complaint process. We do have an 800 line. We have an email to send complaints into. We ask that providers identify the plan and enrollee and any background documents they have in correspondence with the plans. We do not usually need the medical record. We usually just need to understand enough to see, what the issue was and information that you received from the plan. It's just a reminder that we're not able to arbitrate or resolve contractual disputes. We do review any complaint that we get in terms of what is authorized in our jurisdiction under public health law. There's a specific kind of complaint that sometimes providers have under prompt pay law, and those complaints are directed to the Department of Financial Services. Certainly, if we get a complaint that is something that is outside our jurisdiction, we do our best to refer it to the agency that has oversight responsibility. And I think some of the other resources we have here as we wind down, here's information about the Children and Youth Evaluation Service. There's certainly the entire process of how a child who may need HCBS services is referred to the Children's Youth Evaluation Service on this page. And what do we have next on this one? Do you want to do this one, Colette?
So this behavioral health transition, if you have some questions or we didn't answer something, you can send it into this mailbox here. But what I would also like folks to know, and I don't know if can I just pull up, if you just go into behavioral health transition, let's see if it works. This one shows.
Which piece are you looking for?
Okay, I'm a liar.
Transition to managed care, that part?
Yeah. Hold on. Looked it up. So there's information, but this 1915C Children's Waiver and the 1115, there's a tab here called the Plan of Care, and this is where the policy is, as well as the FAQ and the fillable forms, the previous webinar. And then somebody asked in the questions about the managed care contacts. So here are the list of each of the contacts by email, et cetera. So you can find your plan. And if for some reason folks are calling or contacting these numbers and it's not working out, then, you know, please let us know. But those are the contacts for communication regarding HCBS services. I don't know what else is there. Just other information. And as we did mention, there is, in the appendix, we put some other slides that may be helpful to folks as we move forward. So we do have a couple questions. So I'm going to just read this one for you, Hope. Is there a conflict of interest having the managed care plan manage the plan of care while also being the one authorizing the service?
No, is the short answer. The conflict of interest rules are different from managed care plans when providing services to their enrollees. The regulations allow plans to appropriately care manage services, even while they might have requirements for prior authorization and review.
So this other person is indicating that the managed care plans, do they understand they need to have communication with the HCBS providers and determination of approval for HCBS services because they're currently notifying the health home care managers? So, you know, we're in this process, I think, of transition, right? So, of course, the plans and the health homes have been communicating because health home services has been part of the managed care benefit package. So there's already been conversations and contracts that have happened quite some time between health homes. So 10-1 was just a couple weeks ago. So, you know, we presented all this material and they have the policy. So I think we're in the middle of this transition where we need to start using the process as well as the forms. So if you're not hearing from a plan, then I would pick up the phone. I would contact them and making sure that you're getting your authorization or whatever it is that you need. And again, I think everyone's just trying to do the best they can at this point to get the information regarding, you know, how especially for transitioning kids, how they're being served. So how long does the managed care plan have to make the determination regarding the authorization of services?
So as I looked at it in the slide deck, it really depends on the timing of the request. If you're asking for services that are already authorized and you're asking for more of those services, that's that concurrent review slide where it's 1 business day from all information and no more than 14 days from the request for the standard review time. When you look at the chart that is in the link, you're going to look at the rightmost column, and it has various timeframes for different scenarios. Some of the statute prescribes a specific time frame for certain services. I think most of the HCBS is going to fall into this concurrent review segment. It's a little further back, Colette, if you're trying to find that slide.
I was.
One more. Two. Nope, I lied. 2 more. Nope.
Oh, you're
that
right.
was.
Like, there it is.
There it is. No, that's
No.
not it. 1 more. This is so funny.
Sorry, we don't want to make anybody dizzy.
Can you go forward?
Mm-hmm.
That's it.
There you go. Sorry. Where did I leave off here? What is the process for when a service is ended or discontinued? I know that the care manager needs to be notified, but does the HCBS provider also need to tell the MCO? I think that would be very nice. Right? You're all communicating together.
It would be a best practice, but in the course of things, the authorization would run out, and there would not be continued services, and the plan of care would be updated, and the managed care plan would get a copy of that updated plan of care and see that the service was terminated.
Right. So has the form been updated to add the client's address? And I think the answer is yes to that, and I believe that has been currently posted. So the forms, like I said, have been updated a couple times, and we keep reposting it. So if it's not there, I will go check, but I'm pretty sure it's there. Can the HCBS provider send the service plan to the managed care in lieu of completing the bottom portion of the notification form for the managed care plan? So unfortunately, no. So our goal here, right, is to have consistency, and we, again, tried to create as the limited amount of forms as possible. So it's really important that the process is the same for everyone. And unfortunately, not all HCBS providers have the same service plan template. So it may have more or less information depending on who you are. So this was our way to have consistent process as well as information. Would the referral process work the same way with voluntary foster care agencies?
So this referral process is set up for HCBS services. So if you're talking about, an agency that is designated to provide HCBS services, it would work the same way. If you're talking about the foster care transition and things we're putting in place to notify a plan that a child has been placed in a voluntary foster care agency, that is a different transmittal form and not part of this process.
Great. For the level of care, should the upcoming year LOC be due on/before the date that the LPHA signed off on the form, or the date that the HCBS CANS was completed and approved? So I want to make sure I understand, but I'll just tell you what the process is, right? As part of your HCBS eligibility determination, you need to have an LPHA signed. So on your annual determination is due 365 days, so it's due on that date. And we have just put out guidance that you should start collecting the paperwork and working with the family to complete that annual determination. And you can start that within 2 months of the due date, 2 months prior to the due date. So I would assume that as you're collecting those documents, your LPHA form will be signed while you're collecting those documents, and then you will complete the HCBS eligibility in the UAS by denoting the date the form was signed. So the form would have to be signed prior to you completing the HCBS eligibility determination. I hope that's helpful. Can you please clarify the requirements for the CANS? Is it the care manager's responsibility to have a recent CANS within 6 months of a referral for HCBS? So I think we need to think about the CANS and the HCBS eligibility determination as two separate and distinct things, even though they can be used for one another. So for Health Home, you must complete a CANS within best practice of 30 days of enrollment, and then 6 months thereafter, and there's a little clock in the UAS, unless there's a significant life event, and then your 6 months clock would restart. HCBS eligibility determination needs to be made when it's determined that somebody needs, wants, or is requesting HCBS services, and then you complete that assessment. So you might not even have a CANS because they came to you directly for HCBS. So the CANS and the HCBS are not linked together. If you already have a CANS in the system, you can use the answers to those questions in your HCBS by linking your HCBS, but it's not a requirement. You can start fresh by starting with an HCBS eligibility determination. Is there a uniform form that is to be contracted?
Used by clearinghouses in submitting claims.
We all read that together. That was so nice.
So I think that would be subject to the clearinghouse and how the clearinghouse accepts claims. I don't know that we can answer that here.
Will it be possible for the authorization form to be unlocked? It's difficult to complete and print. So is it locked? All right, we'll have to go and look at that because I guess I didn't realize it was locked or that you're losing information. So we'll go check to see if we can fix that. So we'll go play around with that.
So there's some good questions for transitioning children as they come in on October 1st. So the idea was that any services that were already in their plan of care with a current service plan and frequency, scope, duration would be honored by the plan. So there wouldn't be a uniform time for the reauthorization to happen. You would need to know what the last duration is that you put up for that child, and understanding that when that duration is coming to its natural end, you want to make sure you reach out to the plan and inform them that you're, officially requesting authorization for further services. Again, as long as you're within that 180-day continuity of care period, there's no utilization review conducted on that. But the plan does need to be notified that you're going to be continuing services past whatever the child came in with on October 1st. And if we need to look at that more, we will. So if somebody has a specific example that they want to send directly to our attention, we can take a closer look at it.
So are providers required to obtain consent in order to notify the plans and submit authorization? But then it's noted here the DOH form 5201 and 5055. So I want to make sure that people know that the 5201 and the 5055 is a health home consent form, and it is best practice for the health home to have the managed care plan on the consent so that you can, freely communicate with them. And then the HCBS provider should also have consent with the managed care plan listed.
So, you do not need to have a specific consent to send information to the plan to request authorization for an enrolled child. There's a consent that is signed when the person enrolls in a plan that covers transactions of that type. However, as Colette mentioned, if collecting consents, usually those forms of best practice would have the person's insurance company included in the consent.
So I can't find it now, but there was a question regarding what happens with the plan of care if the child's on a wait list. Mm-hmm. So obviously if a child is not receiving the HCBS service that they were referred to because they're on a wait list, then this process can't be followed. However, for care managers that may be on the call, a child who's in waiver must receive at least one HCBS service on a monthly basis to continue to remain eligible for the waiver. So, obviously once a child is in a service, then this process will be followed. And I also just, again, direct folks to the plan of care policy, the workflow policy, because there's some questions about when and how to update the plan of care with frequency, scope, and duration. And as we mentioned, it does vary, because if you refer a child to, let's say, 3 HCBS services, one of them is on a wait list, and the other 2, they are in getting the services, but one turns around frequency, scope, and duration quickly, and another one does not, then we do go through the policy of how that plan of care may have to be updated multiple times and then sent to the plan. So I think we've reached our time, but I also feel like we've answered, hopefully, most of the questions. As I showed you on the website, we do have an FAQ from our previous webinar, and we will compare and contrast these new questions with those, and then update anything that may be missing to ensure that everyone gets the same information. So we really hope that this was helpful, especially for our HCBS providers, because this was the request from the HCBS providers and stakeholders to present this information specifically. And I would encourage HCBS providers, as others, if there's other information, trainings, webinars that you are in need of that will help you through the many transitions we've been going through, then please reach out to us in the many mailboxes that you have seen here, so that we can try to meet your needs and be responsive to your questions and your training needs. So appreciate everybody's time. Caitlin?
Yes, I just want to thank everyone for joining, and just remind you that the slides and recording will be posted to ctacny.org. All right, thank you, everyone.
Great, thank you. Have a great weekend.